Welcome, everyone. This is Jennifer Wilson. I am a registered dietitian at Nestle Health Science. I will be moderating today's presentation entitled Common Challenges Conducting NFPE, Focus on Elderly. Financial support for this presentation was provided by Nestle Health Science. The views expressed are those of the presenter and do not necessarily represent Nestle's views. The material is accurate as of the date it was presented and is for educational purposes only and not intended as a substitute for medical advice. I am very pleased to present today's speaker, Sandra Ostoff. Sandy Ostoff worked at the Cleveland Clinic in Cleveland, Ohio for 39 years, where she was an advanced practice level 2 dietitian for the Center for Human Nutrition and the Digestive Diseases and Surgical Institute. She retired in 2019 and formed her own limited liability company. Sandy is certified as a nutrition support clinician and is an active member of ASPEN and the state chapter, the Ohio Society for Parenteral and Enteral Nutrition, where she served as president and dietitian at large. She is published in peer-reviewed and non-peer-reviewed journals and has written several book chapters in nutrition support. Sandy has lectured to physicians, dietitians, nurses, and pharmacists on many topics of nutrition and has led hands-on workshops for dietitians on how to successfully conduct nutrition-focused physical exam techniques around the country since 2014. Welcome, Sandy.
Thank you so much, Jen, for the lovely introduction. And thank you for attending this virtual seminar. Today, I'm going to be talking over about 3 objectives. The first, I'm going to describe the conditions of sarcopenia and sarcopenic obesity in the elderly as they relate to malnutrition. Secondly, I'm going to discuss physical frailty in the elderly and how it's associated with malnutrition. And finally, I'm going to identify challenges when conducting a nutrition-focused physical exam for inpatient as well as outpatient elderly patients. In 2018, there were about 52 million people who were elderly in the US, and this number is going to only increase. By the year 2029, the last baby boomer will have reached 65. Unfortunately, I just turned 65 last month, so it doesn't sit well with me that now I'm new in this elderly category when my mind is still like at 45 years old emotionally, but physically I could tell the difference. Malnutrition occurs in about 27.4% of all elderly. And the prevalence, as we all know, of hospitalized malnutrition is about 15 to 60%. And the range is so different because it depends on the documentation. The estimated annual cost of disease-associated malnutrition in older adults in the U.S. is $51.3 billion a year. Now, we all know the Academy and ASPEN's 6 characteristics. And as you could see, the 6 characteristics here, many of them you will see repeated when I go over sarcopenia and frailty. Now, we know with our nutrition-focused physical exam assessment that we need 2 or more recommended for a diagnosis. So why are the elderly at risk for malnutrition? Well, first of all, they have many comorbid conditions like diseases like diabetes, heart disease, lung disease, stroke, osteoporosis, renal disease, and not that they're disabled, but they're not really physically active. Less than 30% are physically active and about less than 18% exercise. Poor nutritional intake, is seen in the elderly. They have a decreased sense of taste or smell. They don't recognize salt and bitter tastes. So they add more salt to food and they crave sweets and they have a slower metabolism. So this could lead to weight gain. And on the other spectrum, they may say, hey, this food doesn't taste good. I don't feel like eating much. And then they lose weight. They also could have chewing and swallowing problems and have ill-fitting dentures. Unfortunately, some become demented and confused as they age. And so to even remember or know to grocery shop, cook a meal, or eat, and they're maybe possibly they're living alone, they don't have help, so they could become malnourished. Unfortunately, when we get older, we lose loved ones and spouses, and so they're more depressed and lonely, and their income is limited. Now, what I wanted to show today is this overlapping conditions of malnutrition, cachexia, with sarcopenia and physical frailty. And you're thinking, how do I tell if somebody is malnourished versus they're just thin and frail due to just aging and not maybe malnutrition? And it's very confusing because these four conditions overlap. So we all know that malnutrition is the deficiency or excess of energy, protein, and other nutrients, leading to adverse effects in body composition with diminished function. There's unintentional weight loss, low energy intake, reduced muscle mass and fat, and this may be associated with inflammation. When you're looking at cachexia, you see weight loss and decreased muscle mass due to disease, and this is associated with inflammation and catabolism. Okay, so now let's turn now to sarcopenia. Look at this. It's similar to malnutrition, loss of muscle strength, loss of muscle mass, and poor physical performance. Now, with sarcopenia, fat loss and inflammation are less relevant. That doesn't mean they don't occur, but they're less relevant. It's more geared toward muscle strength and mass, and I'll go over that in a little more detail. Physical frailty, unintentional weight loss. There you go again. That's malnutrition. Exhaustion, weakness, slow gait speed, low physical activity, and inflammation is more prevalent in frailty. So let's go over sarcopenia and frailty in a little bit more detail. Dr. Erwin Rosenberg coined the term sarcopenia in 1989, and it is a muscle disease with low muscle strength and low lean muscle mass and or poor physical performance, which is associated with adverse outcomes such as falls, fractures, physical disability, and mortality. How many of you know of many elderly, maybe your grandparents, your parents have fallen? 4 of my friends' moms have fallen in the last 5 years and have broken shoulders and elbows and arms. They're doing fine, but sarcopenia, the evaluation of the presence of sarcopenia should be done if a patient has a history of falls and weakness, slowness, self-reported muscle wasting, or difficulties with activities of daily living. Now, sarcopenia, or primary, I should say, sarcopenia is related to aging. There is also secondary sarcopenia, which you may have heard. This is not related to aging. Anybody could have this in your 30s, 40s, 50s. And this is related to disease specifically, like organ failure, malignancy, sedentary lifestyle, poor nutrition. But for today, since we're talking about the elderly, I'm going to be talking about primary sarcopenia. Sarcopenia is more focused on muscle strength and mass. And direct U.S. healthcare costs of sarcopenia are estimated to be over $18 billion a year. Now, what happens to muscle with aging? Aging disturbs the homeostasis of skeletal muscle. Skeletal muscle declines from about 60% of total body mass when we're young adults to about 40% when we're 70 years old. Loss of muscle strength is more rapid than loss of muscle mass. And you would think, okay, isn't muscle mass kind of related to muscle strength? You have to have mass to have strength. The loss of muscle mass is only part of the cause of decreased muscle strength. There's many other things going on as we age. We have loss of type 2 muscle fibers. Now, type 2 muscle fibers contract more rapidly than type 1 muscle fibers, which contract slower. So we have less of the fast contracting muscle fibers. As we get older, we're more inactive. As we get older, fat infiltrates in our muscle, and this lowers the muscle's quality, performance, and contributes to inflammation. So you have inflammation and oxidative stress, or increased pro-inflammatory cytokines. And finally, our hormones change as we get older. Women lose estrogen and progesterone, and men lose testosterone. What are the ways to identify sarcopenia? Now, muscle strength is a stronger predictor of long-term functional status than muscle mass. So over the last 10 years, they have changed the definition to say loss of muscle strength. So when somebody who's older has loss of muscle strength, they are diagnosed with probable sarcopenia. If they also have loss of strength and muscle mass, they have confirmed sarcopenia. If they have all three, loss of strength, mass, and low physical performance, it is considered severe sarcopenia. Now, currently, biomarkers for sarcopenia are not available in the clinical practice. So let's look at how we determine muscle function, strength, and mass. In the left column, I have listed muscle function and strength. Now, strength, we all know from our nutrition-focused physical exam what the functional status is hand grip strength. So weak grip strengths for women would be around less than 16 kilograms of force for women, and for men, less than 27 kilograms for men. Now, did you ever grip a dynamometer? It's really hard to grip, and you think that needle's not moving anywhere, but it is. But as we're weaker, it doesn't go up as far. Now, manual muscle testing evaluates the muscle group function from upper and lower body against manual resistance. Now, physical therapists could use the dynamometer and manual muscle testing, as well as dietitians, but not all dietitians do. Now, when you're looking at function, you could look at gait speed. Now, somebody who is disabled in walking, their speed in walking, would mean that they would take, it would be less than 0.8 meters per second. So 0.8 meters is about 30 inches. It would take them less than a second to go 30 inches. I had to test this out for myself. I was able to go 60 inches in a second. So I was like, phew, I have good gait speed. All right. The next test for function is time to get up and go, where a person is sitting in a chair. They have to get up from the chair, walk 10 feet, come back and sit down. And they have to do that in less than 20 seconds. Otherwise, they have low physical performance. There's the stair climb. Are they able to walk a flight of stairs? There's the chair lift, where they have to sit in a chair, put their hands crossed in front of them, and stand up and sit down as many times as they can within 30 seconds. If they don't hit 11 or 12, that's considered low physical performance. Try that sometimes. Now, as far as muscle mass, you have more of the radiological studies that determine muscle mass in an individual. The DEXA scan is the easiest and best tool. It not only measures bone mass, but it also has muscle. The bioelectrical impedance is another tool that you could use, and a lot of physical therapists have that handheld thing where you could check for muscle mass. CAT scans, MRIs, and ultrasounds. Now, ultrasounds can be used in the clinical setting with a portable machine, and I'll mention that in the next slide. But look at the bottom, palpation and visual inspection. This is what we do as dietitians with the nutrition-focused physical exam. So we are palpating their muscle and we are visually inspecting their muscle. So we as dietitians contribute in the documentation of the medical record of muscle mass. A colleague of mine, I don't know if I want to say she taught herself, but she was interested in this portable ultrasound machine in the ICU several years ago. And I don't know if a resident or a nurse kind of showed her how it's used. She started using it on her patients just to see what happened. And then after she felt more proficient in it, she did a study. And it was published this year. It's not even, I don't think, in print yet. But she looked at 52 ICU patients against 15 healthy controls. I was one of the healthy controls, by the way. And she measured the quadricep muscle layer thickness at enrollment of the study and 1 to 2 times after within over like a 10-day period. And she found that from the midpoint in the quadricep, from the knee or patella to the hip or the anterior superior iliac spine, they lost about 3.2% per day of muscle thickness. Now, when she measured 1/3 distance from the kneecap into the thigh or the quadricep, she found 2.9% loss, and this was statistically significant. She found no significant loss of the quadricep muscle layer thickness that was found in healthy controls. The prevalence of sarcopenia could be as high, depending on what studies you read, 50, 60%. But the European Working Group, which is a very prominent group in the world, and the Asian Working Group feel that it's about 13% of their populations. The International Working Group feels about 10% prevalence in their society. And then the foundations for National Institutes of Health say about 19. Now, there was a study done by SARI in 2015, and it was a prospective observational study that looked at 103 people that were elderly over the age of 65 at risk of malnutrition or with malnutrition that were admitted to a geriatric clinic. They did bioelectrical impedance for the muscle mass, hand grip strength for the muscle strength, and gait speed for the physical performance. And they found that out of the 103, 21% were considered sarcopenic. Now, what's the treatment for sarcopenia? Well, first of all, look at the first three. It's related to nutrition. So we as dietitians have to make sure that our elderly have adequate protein intake, and we could provide high protein oral supplements. Vitamin D builds muscle mass, and so it's important to check in the elderly vitamin D levels, the 25 hydroxy vitamin D levels, and supplement. Now, when I was working, I worked with intestinal rehab and short bowel patients, so we would check their vitamin D levels every 3 months. And normal was like 31 to 80. So if they were like between 20 and 31, we would prescribe 2,000 international units of vitamin D. And as the level got lower, we would increase the dose, and then we would watch and monitor the levels to make sure that it was improving and not going too high. Also, omega-3 fatty acids may increase muscle mass and function in the elderly, so we need to educate them to eat more salmon and canola oil and avocados and things that are high in omega-3 fatty acids. The physical therapist could use resistance exercise. That helps against sarcopenia. Now, according to Cruz-Gentoff in their 2019 Lancet article, they said that there was no specific drugs that have been approved for the treatment of sarcopenia. But many trials have been done with hormones like testosterone and estrogen, progesterone, the androgen steroids like oxandrolone, and human monoclonal antibodies like bimagrumab. So a lot of studies have been done. And muscle mass did improve with the elderly and sometimes strength, but results weren't always consistent with larger studies. So more research is needed in this area. Okay, now I'm going to quiz your knowledge on what we just talked about with sarcopenia. You have an 83-year-old female that was admitted with a shoulder fracture from a fall. Her medical history is atrial fibrillation, heart failure, diabetes, and hypertension. She does little activity at home and lives with one of her daughters. The physical therapist tested the patient's hand grip strength and gait speed, which were below normal for her age. The DEXA scan shows low lean muscle mass. So does this patient have probable sarcopenia, confirmed sarcopenia, or severe sarcopenia? I'll give you a few seconds to think about it. You probably already know. If you said the answer was C, you were correct because all three conditions existed: low strength, mass, and poor performance. So good for you if you got C. Okay, let's move on to sarcopenic obesity. This is the definition of sarcopenic obesity is the same as sarcopenia: reduced muscle mass, low muscular strength, and low physical performance, but it's accompanied with high fat mass. Notice, unlike sarcopenia, it doesn't have an ICD-10 code yet. It's caused by aging, sedentary lifestyle, unhealthy diet habits, and this increases mortality. The incidence of obesity in the elderly are about 29%. And sarcopenic obesity is significantly associated with cardiovascular disease. Now, what happens with dietitians trying to assess these patients, it's difficult to assess muscle mass with palpation alone. So the increased risk of unidentified malnutrition could be common in this group. Treatment, of course, would be weight loss, adequate protein intake, and combined exercise. The criteria for identifying sarcopenic obesity requires direct measurement with the DEXA scan, bioelectrical impedance, CAT scan, MRI, like I mentioned before. Men are considered obese if they have a body weight of greater than 25%, and women if they have a body mass of greater than 35%. Now, rates of sarcopenic obesity increase with age. So by the time people get to be 80 years old, it could go as high as 48% for females and 28% for males. So I drew this little diagram here just to show this MRI. And with no obesity, you have the thinner layer of the adipose tissue with a lot of muscle there. With obesity, you could see with the MRI or the CAT scan, this thick layer of adipose tissue and a smaller muscle. The prevalence of sarcopenic obesity are about 13% in men and about 33 to 34% in women. And rates increase with age, which I already said already, reaching about 80 years old. And they go up to 48 and 48 for females and 28 for males. Okay, now we have the question. Which of the following is not associated with sarcopenic obesity? A, reduced lean muscle mass and strength. Rates of sarcopenius obesity decrease with age. Infiltration of fat into the muscle. And poor diet habits. I'll give you a few seconds. This is an easy one. If you said B, you were correct because the rates of sarcopenic obesity increase with age. Okay, let's move on to the frailty. This term frailty was coined in about 2001. The term evolved around 2001 with the studies from Dr. Linda Fried and Dr. Ken Rockwood. Linda Fried came up with the physical phenotype, and Dr. Ken Rockwood's group came up with the deficit model, and I'll go over those in a little bit. In 2012, 6 major international and U.S. societies attended a consensus meeting, and they came up with the definition of frailty and physical frailty. And frailty, as you could see, also has an ICD-10 code for reimbursement. Frailty is a clinical state or condition in which the individual is vulnerable to adverse health outcomes or dying when exposed to a stressor. A stressor could be a fall, could be an accident, could be an infection, it could be COVID. Physical frailty is a medical syndrome with multiple causes and contributors characterized by diminished strength, endurance, reduced physiologic function that increases an individual's vulnerability for developing increased dependency and or death. Now, frailty could either be physical or psychological or both. Sarcopenia is a substrate of physical frailty, but frailty concentrates on more weight loss and weakness, where sarcopenia, the difference, because they overlap, the sarcopenia concentrates more on loss of muscle strength and muscle mass, and both are part of the aging process. So the path of the aging process goes from a state of robustness and good health, and then passes on to sarcopenia, over to frailty, then disability, and eventually death. And like I said, frailty goes beyond physical factors. You could have psychological, social, and cognitive factors with frailty. Frailty and malnutrition are related. Both have the same characteristics. As a matter of fact, listed here are 5 of the 6 characteristics by the Academy and ASPEN's criteria: weight loss, poor nutritional intake, decreased body mass of muscle and fat, and diminished function or weakness. There was a dietitian survey that was done. It was published this year in Nutrition Today, and They sent out an email, you may have received it, to about 9,000 dietitians across the country, and they only got 10% responses back. So they had about 900 dietitians that responded. What they wanted to do, since they saw that there was overlap of malnutrition and frailty, they wanted to identify opportunities and challenges related to the two conditions. They found that 64% of dietitians did work with elderly. They found that 90% were unfamiliar with frailty screening tools. Now, I've heard of frailty, but I was unfamiliar when I was practicing of frailty screening tools, and they're really not that hard. 68% agreed that dietitians should play a role in screening for frailty. They concluded that dietitians working with the elderly need skills-based competency, education, and training regarding frailty. Like I said before, frailty is associated with functional decline, like weakness and exhaustion, loss of independence, deterioration of health status, falls, delirium, and acute confusion, an increased risk of hospitalization, and ultimately death. So that's the difference between sarcopenia, which is more muscle strength and mass, versus frailty. Frailty screening provides a means to identify the elderly most vulnerable, which affects their quality of life and healthcare costs. There, in that 2012 consensus meeting, they all decided that all persons 70 or older, or if they have lost greater than 5% of their body weight or equal to 5%, should be screened for frailty. Now, there's over a dozen instruments that screen for frailty. You have the cardiovascular health study frailty screening measure, and this measures weight loss, exhaustion, low activity, gait speed, grip strength, which is from the Dr. Freed's physical phenotype. The clinical frailty scale is a 9-category scale where 1 is like perfectly very fit, all the way to 9, which is terminally ill. There's the Frail scale, which is self-reported. It could be completed in 5 minutes. So if people tell you that they're fatigued, F for fatigue, R for resistance, inability to climb a flight of stairs, A for aerobic, inability to walk a block, illnesses, if they have greater than 5 illnesses or comorbidities, and loss of weight, which is that equal to or greater than 5%. Now let's look at the deficit model and the physical phenotype in more detail. The deficit model involves the Frail index, and to determine the Frail index, you have to take the number of health deficits divided by the number of health deficits measured. So health deficits would not only be chronic disease like diabetes, heart disease, lung disease, COPD, stuff like this. It would also be laboratory findings, physical function tests, cognitive or sensory difficulties, anything, any other health problems. And so the physician or the clinician would have a list of about 30 to 70 items in the domain. I think they're cutting down to maybe like 30 now. And so they would take the patient and check off how many of the deficits are indicated in that individual patient. So if somebody has 15 out of 30, they have a Frail index of 0.5. And the scale range of the Frail index is 0 to 1. So the closer somebody is to the number 1, the greater the incidence of frailty. The physical phenotype is a little different, but it makes up 5 components: weight loss, exhaustion, weakness, slowness, and reduced physical activity. And the scale obviously is 0 to 5. So if somebody is robust and well fit, they have no components. Pre-fail, they would have maybe 1 to 2 components. And if they were frail, they would have equal to or greater than 3 components. There's a study done back last year, was published from Harvard Medical Center, and they compared the physical phenotype to the deficit model or the Frail index. And they looked at 228 patients that were over 70 years old with severe aortic stenosis. And they divided the groups into the surgical group and the transcatheter group. Notice here that the surgical group is much younger than the transcatheter group, 78 years old to 85 years old. When they took a look at gait speed, you could see the difference in gait speed. It's much less. It's much slower than the younger elderly. When they took a look at grip strength, the younger elderly had a stronger grip strength than the older elderly at only 16.8. When you look at physical phenotype and the Frail index, the older elderly in the trans catheter group were much higher. So in the physical phenotype, it was 84.6%. That equates to about 4.2 out of 5 components for the physical phenotype. And then the 39% is about 1.8 out of 5 components. So it's much different, and they were all statistically significant. And what they found overall, the phenotype for frailty in this group was 65%, and pre-fail 35%. That's 100%. That means nobody in this group was robust. The other thing that was interesting is that they found the Frail index was a better predictor of pre-op risk, recovery, and death than the physical phenotype. The prevalence of frailty in the community versus nursing home is like twofold. As you could see, elderly who are living at home maybe have a rate of frailty about 15%. Take them to the nursing home, though, when you average the nursing home elderly, it's about 30%. The younger elderly, only about 10.7%, whereas when you get into the older elderly of 85 to 89, you get closer to 40%. Women have more frailty than men, as you could see here. And when you look at the robust category, the younger elderly are much more robust than the older elderly, and it's very significant. Now, the treatment for frailty can be prevented and it's reversible, and that's terrific. Dietitians can make a difference with frailty. We need to make sure our patients have calorie and protein support, giving them nutritional supplementation, making sure they're eating okay. We need to check that vitamin D level since it builds muscle strength. Although in the frailty studies, vitamin D does not treat frailty alone. You need calorie and protein support, vitamin D, and physical activity. And physical activity or exercise improves walking speed, stair climbing, and balance. Also, physicians need to look at how many medications a patient is taking, because medications could also play a role in frailty. If too many, it could make somebody more frail, they said in the research. Okay, let's test your knowledge now on frailty. You have a 77-year-old male that's seen in the outpatient clinic with heart failure, hypertension, prostate cancer, and COPD. He reports a 10-pound weight loss, or 6%, over the past month after his hip surgery. His 25-hydroxy vitamin D level is 29. What is the best nutrition recommendation? And I'll give you a few seconds here. A, be screened for frailty, start a multivitamin, begin exercising. Be screened for frailty, start 2,000 international units of vitamin D and a high-calorie, high-protein shake. Or be screened for frailty and start 10,000 international units and eat frequent small meals. All of them can be done, but there's one best answer, and I think the best answer is B. Be screened for frailty. Make sure that you give them the 2,000 international units. I think 10 is a little bit too much for a level of 29, and a high-calorie, high-protein oral nutritional supplement. So if you got B, congratulate yourself, you got it right. Okay, let's go over now challenges when conducting a nutrition-focused physical exam. It's really difficult to determine loss from malnutrition versus aging. I've just explained to you how aging decreases muscle mass and function. So how do we tell the difference between malnutrition and aging? The thing that you have to do is look at the whole picture. If you see, when you're doing your nutrition-focused physical exam, you're looking at weight loss and poor intake, chances are they have malnutrition, maybe in addition to frailty or sarcopenia. So the loss of lean muscle mass and muscle strength in the aging process limits participation in the exam. Excess adipose tissue for those who are overweight limits observation and palpation of underlying muscle mass. And I feel that hospitalized patients, for myself, were always more challenging than outpatients. They were sicker, they may have had IVs, tubing, they may have just come from surgery, and they were unable really to participate in the nutrition-focused physical exam for me to look at all 7 muscle areas and all 3 fat areas compared to the outpatient setting, which they were in their street clothes, they were healthier, they were able to participate more. So what's the dietitian's role? The first thing, once you go through all the medical record and if you've interviewed the patient, is to determine the etiology. You want to know if it's chronic disease or acute disease or illness or injury. So you want to make the etiology first. Now, if you do say that the etiology is from chronic illness or acute illness and injury, you know that's associated with inflammation automatically. And inflammation in itself is associated with muscle loss, strength, and function. And inflammation, like I said before, is less relevant with sarcopenia. So it could be that this is malnutrition. So this needs to be considered when you're doing the nutrition-focused physical exam. So of course you would identify their percent weight loss and their energy intake over time, and then perform a nutrition-focused physical exam on every elderly patient that is screened for moderate or high malnutrition risk. Where I worked, the patients would be screened nutritionally using the malnutrition screening tool by the nurse. And there was 2 questions. Did you lose weight and how much? And is your appetite good or is it changed to poor? So when the points added up to 2 or greater, the consult was automatically referred to the dietitian. Anything under 2 went to the dietetic technician. Now, as dietitians, we would always check out to make sure the answers were correct. There was occasionally times where I would get a consult from the screen and the person told me, I didn't lose that weight, my appetite's fine. And then I would refer them back to the technician. But most of the time, when a person is screened, you are going to be consulted because that person is at higher nutrition risk. And so we would have to do a nutrition-focused physical exam on every one of these consults. And what we would do for the ICU is do it initially within 48 hours of admission, and then within 10 days later for follow-up every 10 days. If they were on the regular nursing floor, we would have to do the exam every 2 weeks. So it's really important that you try to do a nutrition-focused physical exam on your population, at least 1 to 2 a day, every couple weeks on your patients. Now, we all know we have to document our nutrition diagnosis in the medical record. And the important thing is discuss this with the physician. And this could be a whole lecture in itself because it's their documentation that counts and gets reimbursement. And it's not our documentation, unfortunately. It's not the dietitians, it's the physician's documentation. So malnutrition is very expensive, as I mentioned earlier in this presentation. And it's very important for we as dietitians to play a role in the reimbursement of diagnosing malnutrition. Now, when you're looking at hospitalized elderly patient, the easiest place to look is the face. That's the most prevalent piece of body part that's exposed. So it's easy to look at the temporalis region and the orbital fat. And as you could see here, this was a patient I took care of about 10 years ago. She was severely depleted. You could see the indentation of her temples, and then under her eyes were very thin with the muscle and skin and bone. It was just skin and bone. There was no fat there. It's easy then to just bring the hospital gown down and check the clavicles. Men's clavicles should not stick out, women's might a little bit, and check the shoulders. However, with the hospitalized patient, it might be more difficult to get that midline rib area pinch for the fat. It might be a little difficult. So all you could do in your note is put unable to assess. When you're looking at the tricep skin fold, it's easy just to take the patient's arm, lift it up, and just check the tricep skin fold. That should be easy for you to obtain. This area, the back, the trapezius muscle and the latissimus dorsi muscles, they're a little bit more difficult. I would say usually 8 times out of 10, I was not able to get this in the elderly or hospitalized patient because they couldn't lean forward. And so I didn't want to, bother them because they weren't feeling well. So if a patient can lean forward, you could check to see if you see muscle wasting in the back area, but it's more difficult to complete. Now, the hand area is readily exposed, so that you should be able to see. However, with elderly hands, they all look malnourished. Malnutrition is one of the reasons for hand muscle loss, but so is aging. So, aging in itself could make the hand muscles lose strength and mass. So, this is a very difficult area. And every elderly hand that I looked at, it looked to me severe. So, the only thing that I could tell you is if your patient tells you, I've lost this much weight and I have not been eating well in the past weeks or months or whatever, you could tie that into malnutrition. But if they tell you, no, this is normal, I'm eating okay, my weight is stable, then really their hand is just from aging and not from malnutrition. Legs can be easier to assess, maybe not, depending on if there's a lot of adipose tissue or fluid accumulation. And in this picture here, you could see the knee is very prominent here. And so you could see the indentation in the thigh area and the calf area there of the quadriceps and gastrocnemius muscles. So these may be easier, sometimes not. Now, there's a lot of challenges with the obese patient. Excess adipose tissue limits observation and palpation under the muscle mass. This was my most difficult patients to assess, especially in the lower extremities. There was no way I could feel for muscle mass. I would be feeling here and always feeling was adipose tissue. So I didn't know what to say, so I put unable to assess. The best thing you could do with the obese patient is assess for changes over time. The upper body shows changes quicker than the lower body. So let's take a look here. So muscle mass depletion is difficult to assess with obesity, no doubt. When you look at this gentleman's picture, if he had a shirt on, he might look a little bit overweight. But to take his shirt off, look at that squared off shoulder that he has there. The best thing to do, since the upper body may show changes quicker than the lower body, is to look at the temples, the orbitals, the clavicles, the shoulders, the triceps, and possibly the hands. Those are your only tools in your nutrition-focused physical exam with the obese. I have seen many of my obese patients just wasting away. You could see their temples were starting to indent compared to when they first came in, and the thinness of the fat around their eyes and their clavicles. And so I could see the muscle wasting, even though their lower extremity was just so full of adipose tissue, I couldn't tell the muscle mass there. Now, since part of the nutrition-focused physical exam is assessing for functional status, I just wanted to mention the hand grip strength again. It's a validated tool, as is manual muscle testing. Now, if a dynamometer is not available, now we had one at the clinic, but we never used it in the clinical setting, and it's not even valid in the ICU. If it's not available or feasible, what we would do was ask the patient about activities of daily living. I would ask them, are you able to walk or do you sit in a chair or a recliner most of the day? Are you bedridden? Are you able to bathe yourself, dress yourself, cook, clean, go shopping, things like this, feed yourself? The patient will be able to tell you, and your documentation can support the assessment of the physical function. Now, manual muscle testing, the way I got involved with this is one of my colleagues, Lindsay Dowhan, and I put her article in here as a reference in JPEN 2015. She evaluated a manual muscle testing. So she taught me how to do it. And I'm going to demonstrate it in the video that you're going to see next because it's hard to explain. But it just evaluates muscle group function from the upper body and the lower body against the manual resistance. So in the next series, Jen is going to show you a 5-minute video that I put together. I wanted to have an 80-year-old friend of mine participate in this outpatient hands-on demonstration, but with the COVID, I had to cancel. So instead, I'm using my 30-year-old son as the outpatient model. So I'm going to let Jen go ahead then and set up the video. Sandy Ostoff from Interactive Nutrition Seminars, LLC. And today I'm going to show you the ease of doing a nutrition-focused physical exam in the outpatient setting. This is my son Jared, and so he's acting as the outpatient, so we are not wearing masks. After I've asked him the weight history and his energy intake history, I always ask the patient if it's okay if I do a nutrition-focused physical exam. Usually 9 times out of 10, patients will say yes. I always wear gloves to make the patient feel comfortable, and I know in today's hospital and clinic setting, you are required to wear masks due to COVID, but we are not going to do that today. So I'm going to do a head-to-toe physical exam. The first thing I do is I check for hair. Now, he doesn't have a lot of hair, and some people wear wigs, so you may not be able to assess for the hair quality. The next thing I do is I check for muscle at the temples. There's a big clamshell temporalis muscle here, and I'm checking there for any indentation. Next, I go to the fat, and I check underneath the eyes for the fat stores. If I feel skin and bone, I'm going to know that they have a moderate to severe malnutrition. The next thing I do is I get my pen light out, and I have the patient look to the right and left, and I'm checking for B-toe spots in the eyes. I'm also checking the oral cavity for any sores at the corner of the mouth, bleeding gums, moistness of the tongue, and a change of color in the tongue, which could be possibly a vitamin mineral deficiencies. The next thing I do is I move down to the clavicles. Men's clavicles will not be sticking out, but I check for the pectoralis muscle here, and if I don't feel ribs and I'm feeling good muscle here, then I know that it's normal. The next thing I do is check the deltoid muscles, and I'm making sure that the shoulders are rounded and not squared off. If they are squared off, you're going to see severe protein or muscle loss there. I sometimes have the patient lift their arms up, so I could also check for the strength of the deltoid muscle. While the arms are up, I check for the tricep skin fold. Men are not going to have a lot of fat in the tricep area like women will. The next thing I do is I check the back for the trapezius and the latissimus dorsi muscles. If I don't see a ledge by the scapula to grab onto, which would be severe or moderate malnutrition or muscle loss of the back, then I know that the muscles in the back are okay, and I go down by the spine on both sides to check. The next thing I do is I check the hands. I'm checking for the interosseous muscles, and I see that these are okay. I could also pinch the nails to make sure the blood returns there. I could also check for skin turgor to make sure they're well hydrated. I have the patient then make an okay sign to check for the muscles by the thumb. Then I have them stand up, and I check for the sides by the midline, by the fat over here. So you would check the midline here. And then I have them sit down, and then I have them extend their leg out, and I'm checking the quadricep muscle, and I put my hand on here to make sure it's strong. If I don't see any like indentation, I know that the muscle is strong. And the kneecap, if they were severely depleted, will be sticking out a lot. It would be sticking out a lot. And then I check the calf muscles, and I have the patient flex their foot toward them so I could feel the strength of the calf muscle. All the while I'm checking for lower extremity edema, and I'm also checking the skin for any rashes, petechiae, for vitamin mineral deficiency. And that's it. That's the whole nutrition-focused physical exam, and it should not take you more than about 1.5 minutes to complete. Now briefly, I'm going to show you the manual muscle testing. 2 manual muscle testing procedures that you would do with the upper body. You have the patient have their hand extended by a 90-degree angle. As you hold their elbow here, you put your hand on top of their wrist and tell them to push their hand toward themselves. And if they could do that easily, as you're pushing down, they're pretty strong. Then you put your hand underneath and have them push down. And so as you're pushing back up. And you do this also with the legs, as you hold onto their knee and put your hand on the top of their ankle and tell them to push the leg up or push the leg down. And so those are a couple techniques of manual muscle testing. So thank you for watching. Okay, so we are going to go over a case study. There was an 87-year-old female admitted for the transcatheter aortic valve replacement for aortic stenosis. She had a past medical history of significant cardiac history with complete heart block, pacemaker placement, preserved ejection fraction heart failure, severe tricuspid regurgitation, AFib, severe pulmonary hypertension, pleural effusion, hypertension, diabetes, and hypothyroid. She was taking Coumadin, iron sulfate, and sliding scale insulin. Her dry weight at the time of admission was 61 kilograms. I kind of guesstimated her usual body weight based on what the case study showed me to be about 70 kilograms, but I don't know if that's true or not. This is what I added. Her height is 155 centimeters, and her body mass index is 25.4. I added these labs, so I don't know. These are not really her labs. Her albumin is 2.9, CRP3, so as you can see, she has a little inflammation. H&H is a little bit low. Blood sugar is okay, and her 25-hydroxy vitamin D is just a little bit low. Her diet order is a heart healthy with high calorie, high protein supplement 3 times a day. You as the dietitian were consulted and you go into the room and talk to the patient, and she tells you that her energy intake has been fair over the past 2 months. So she tells you less than or equal to about 75% for greater than a month. She's not a big eater. She has no known food allergies. She did not take an oral nutritional supplement prior to admission. She reported a 19% weight loss over the past 2 months, but some of this was related to fluid loss from a thoracentesis. So I kind of guesstimated that currently below her dry weight from that thoracentesis loss, she's probably like 13% below her usual body weight. Fluid accumulation, she has no current edema. And when you asked her, and I added this into, you asked her if she was able to bathe, cook, and do light housework, she said she was. So you did a nutrition-focused physical exam, and the temples, the clavicles, the shoulders, were moderate, and then shoulders were severe. The back was moderate. The hands were severe, which doesn't surprise me at 87 years old. The calves were moderate, and the thigh was unable to be assessed. The subcutaneous fat, the orbitals were moderate depletion, triceps moderate depletion. So we could look at the muscle mass and say, okay, there's 4 moderate depletions there and 2 severe. So I would go by the majority, even though there was a couple severe, I would say that this area was moderate loss overall. And the subcutaneous fat mass, moderate loss overall. So we could agree on that. Now I embellished this a little bit too. This did not happen really, but I put this in. The physical therapist assessed her hand grip strength and found that it was 12 kilogram force. Her gait speed was 0.6 meters a second. They did a DEXA scan and they found her muscle mass showing decline in lean muscle mass. So you may want to get your pocket cards out to determine the next question. What is this patient's nutritional diagnosis? It's going to take a little bit. Do you think that A, she has severe protein calorie malnutrition of acute illness? Because first you have to determine the etiology. Is it acute or chronic? So you have to decide there. So if she was post-op, it would definitely be acute. And this is due to moderate loss of muscle and fat stores and the 13% weight loss over 2 months. Or B, severe protein calorie malnutrition of chronic illness due to moderate loss of muscle and fat stores and a 13% weight loss over 2 months. Or C, severe protein calorie malnutrition of acute illness due to less than or equal to 75% of energy intake for 2 months with the 13% weight loss over 2 months. So which is the best answer? If you look at your pocket cards, you'll be able to tell, and it kind of takes a few minutes. And since we don't have that time, I'm just going to share the answer with you. So the answer is A, severe protein calorie malnutrition of acute illness due to moderate loss of muscle and fat stores with 13% loss over 2 months. The reason that answer B is not correct is that to be of chronic illness, severe protein calorie malnutrition of chronic illness, you need severe muscle and fat loss. On the pocket card, it will say severe loss of muscle and fat, not moderate. Answer C is wrong because to have acute severe protein calorie malnutrition of acute illness, you need less than 50% or equal to 50% energy needs for greater than 5 days. So this is why A. So let's look at the pocket card and we could look here. So we decided it was acute illness or injury with severe inflammation. So let's look and see if we have, how many do we have in each category? Well, her energy intake was insufficient, so that was moderate, not severe. Okay, her unintentional weight loss was severe. Her loss of subcutaneous fat was moderate. So right there we have 2, so she is severe. Loss of muscle mass, moderate. She didn't have any fluid accumulation. And even though she told you her functional status was fine, you could put no change, because I had added the physical therapist and the DEXA scan, we could say she has a decline in physical function. So you could see there that she has the severe malnutrition. Okay, the next question. Based on this patient's diagnoses, age, malnutrition, DEXA scan, and physical therapist's assessment, does this patient most likely have malnutrition and frailty, malnutrition only, or malnutrition and sarcopenia? The best answer, based on the data that we have, would be malnutrition and sarcopenia. And actually, she has severe sarcopenia because her hand grip strength was poor, her DEXA scan, the muscle mass was poor, and her gait speed was low. So she had poor physical performance. Now, she could also be frail too, but they didn't screen for frailty, so we don't know. So the Frail index and the phenotype, physical phenotype was not done, but she could be frail also. But the best answer for this, with what the data we had, was malnutrition and sarcopenia. And then finally, the last question, true or false? Would you want to educate this patient on a high-calorie, high-protein diet with oral nutrition supplement 3 times a day and start a 2,000 international unit oral vitamin D gel cap daily and follow up in 2 weeks in the outpatient clinic? True or false? All 3. And of course, the answer is true. So in conclusion, malnutrition, sarcopenia, and frailty are overlapping conditions, and it makes it challenging to conduct a nutrition-focused physical exam with the elderly. So well, what's malnutrition and what's just frailty or sarcopenia? Sarcopenic obesity limits observation and palpation of underlying muscle mass. So it's difficult. It's best to, then go to look over time and look at the upper body changes. Every elderly patient that's at risk, nutrition risk, should be evaluated for malnutrition using the nutrition-focused physical exam. And we as dietitians play a huge role. We could find nutrition interventions that could prevent or delay malnutrition, the loss of muscle strength and mass. We could prevent physical frailty. We could improve the health of the elderly, decrease length of stay. That's huge. Your hospital will love you. Reduce readmissions and healthcare costs, reduce falls, fractures, and loss of independence. So now I will take questions that have come in.
Well, thank you, Sandy, for an outstanding and timely presentation. The first question is, what is the difference between weakness and loss of muscle strength?
That is a good question. You would have to I would say it's probably the same thing, but loss of muscle strength, because it's related to aging, the loss of muscle strength would be tested by the hand grip strength. That's a validated tool. So that would mean that the patient is considered weak. Okay, so I would say it's very similar. Because when you do the frailty, you're asking patients if they're weak. So I would say that's similar. It goes hand in hand.
Okay.
Very good question.
Okay, the next question is, Should muscle loss only be diagnosed if malnutrition is suspected with impaired PO intake and/or weight loss? If it appears a patient has muscle loss, but we are unable to confirm weight history and/or PO intake, would you still diagnose muscle loss or put unable to obtain? If muscle loss is determined to be attributed to aging, do you think this should be noted under the NFPE documentation?
You could note it under the NFP documentation. However, I would put unable to assess. If you don't know weight changes or oral intake changes, that's two huge things of the nutrition-focused physical characteristic that you need to document malnutrition. Otherwise, what you could do is ask the patient, and I would do this all the time in the elderly or anybody, is this normal for you? I had a colleague, for instance, that was healthy. He ate well, but he was a marathon runner. So his temples were always indented. So if somebody was coming in and assuming, oh, all indented temples are malnourished, moderate malnutrition, that's not the case. Because if this is normal for them, so if there is no weight loss, no poor intake, you probably would say, no, you can't say that this muscle loss is from malnutrition. It's just probably from aging. Did that answer? And if you don't have weight and intake, you don't know then if the muscle loss is from malnutrition. I mean, that's one of the key things that you would need. You need the whole picture. So I would say if they're elderly, you could ask them, is this normal? Is this what your temples normally look like, your clavicles, your hands, things like this? So you really can't assess.
Yeah.
You can't assess.
Yeah, she said that yes, you did answer the question.
Yeah.
All right, so another question is, how can the patient's hand grip strength be assessed and documented if the dietitian has not been trained on doing that?
Oh, another very good question, because the dietitian should be trained on it. Like I said, we had a dynamometer where I worked, and I never used it once. It's more used for research or when you're demonstrating in a lecture to dietitians the hand grip strength. And studies have shown in the intensive care, you're not even going to get an accurate reading at all. So, and I want to tell you, because it's real important because Therese Schollard writes a really good article for the Academy on hand grip strength that you could read, and she has a toolkit with it. But what's really important, and Lindsay taught me this, my colleague, is that you have to coach the patient as they're gripping that, and you have to say, keep squeezing, keep squeezing, keep squeezing. I mean, you have to know what to do. So if you're not trained, I would say it's probably not as accurate. You'd probably have to do it frequently and then feel, more competent.
Wonderful.
So, yeah.
Thank you. On behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice. Enjoy the rest of your day, and please be safe.